do have quorum in our meeting. And I do anticipate Leanne to join us relatively soon. And I think Beth is going to be joining us overhead. I'd like to begin this meeting with an opening prayer, and then we'll do our Pledge of Allegiance. Dr. Davis, you have done so well with prayers. Do you think you can help us with that? If everybody would stand.
Thank you, Dr. Lampton. Let's pray. Father, we thank you for the opportunity to serve the people of the state of Mississippi today. We come before you and ask for your presence here. We ask for you to give us wisdom that we need to make sound decisions. Lord, we pray that you will help us to keep the well-being of the citizens of Mississippi at the forefront of our thought. We wouldn't be distracted by any other considerations. We pray that you would be honored by the way that we conduct ourselves and the decisions that we make this meeting today. Thank you so much, Lord, for the people in this building and in the buildings around us who dedicated their lives to the well-being of our fellow Mississippians. Pray for their health, well-being, and we thank you again for your love for us. In Christ's name I pray. Amen.
Amen. Now for the Pledge of Allegiance. Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. You may be seated. This is National Public Health Week. It started on Monday. It's an important time, as Dr. Davis prayer noted, for us to remember the great staff of this department and the heroic work that they engage in every day that often goes unnoticed by the rest of the state. But this board notices it, and many in the state noticed it, and we appreciate the great work y'all are doing. Someone who played a great contribution to public health in Mississippi was Dr. Elaine Hayes Anthony. And she's somebody that all of us loved and cared about and recognized her great leadership abilities. This board approved a resolution for her. And on behalf of the board, I would like to present it to her husband, Dr. Eddie Anthony, her husband for 43 years. And so much of what Dr. Elaine Hayes Anthony accomplished and gave was because of him. And Dr. Anthony, will you help me? Come on forward while I read it. And it's I didn't write it, but it is long. Okay. So I don't know who to blame for that. But this recognizes the distinguished service of Dr. Elaine Hayes Anthony. And whereas Dr. Elaine Hayes Anthony, member of the Mississippi State Board of Health, passed away on March 5th, 2026 after more than 19 years of service to public health. And whereas Dr. Elaine Hayes Anthony, since her initial 2007 appointment to the Board of Health and continuing to her most recent reappointment this year, selflessly dedicated herself to serving the state by providing policy direction for the Mississippi State Department of Health, while also managing a career that spanned higher education, public relations, broadcasting, and community leadership. Whereas Dr. Elaine Hayes Anthony made history at WJTV 12 as the first Black woman to serve as an anchor, producer, and reporter at the station, opening doors for women and people of color across Mississippi newsroom. And whereas Dr. Elaine Hayes Anthony's career later expanded into higher education, where she served as chair of Jackson State University's Department of Journalism and Media Studies, and was appointed acting president, which she so loved, and was founding head of the Department of Communication at Belhaven University. And whereas Dr. Elaine Hayes Anthony previously served as assistant superintendent of public information and staff development for the Jackson Public Schools, And whereas Dr. Elaine Hayes Anthony is the first Black woman president of the Mississippi Association of Broadcasters, is remembered as a force of mentorship and advocacy. Whereas Dr. Elaine Hayes Anthony, as a member of the Board of Health, helped select 4 outstanding state health officers, chaired the board nominating committee, was a member of the Cannabis, Certificate of Need, and Maternal and Infant Health committees, and was instrumental in overseeing one of the most successful COVID-19 vaccination programs in the nation. Whereas Dr. Elaine Hayes Anthony continually worked with the members of the State Board of Health to improve the quality of life of all Mississippians. Therefore, be it resolved on April 8th, 2026, that the members of the State Board of Health wish to express our gratitude and respect for Dr. Elaine Hayes Anthony and the lasting impact she made on the health of the residents of Mississippi. On behalf of y'all, I present this to Dr. Anthony.
I mean, for the last 17 years, I remember first got on to it, and I said, "Now you got something about what to do?" She said, "Well, I don't care. I'm gonna make sure that our people in the state of Mississippi have good health care." And that's what she fought for.
That's what she did.
And I want to thank you all for supporting the young baby.
Thank you for sharing.
Chairman Matt, I say something brief.
I wish you would.
I can't tell you how instrumental Dr. Hayes Anthony was in helping me get my feet under me that first year as state health officer. And I always loved her phone calls whenever after we had some type of public messaging and giving good feedback on how well we communicated and maybe how we could do a little bit better. And you better believe I took every bit of advice that she gave. I don't know of anyone who has been more passionate in supporting public health. The State Department of Health is so grateful for her service. Thank you.
And in one little memory back, she was appointed in 2007 when the board was reconstituted. And Governor Barber appointed her because he trusted her to do the right thing. And from that first meeting in 2007, when we met in the Attorney General's office to reconstitute the board and to choose a state health officer, which Dr. Ed Thompson was the one chosen. She was a strong advocate for Dr. Thompson, and she was a strong advocate for bringing the Department of Health and the Board of Health back to where it had been. And she played a major role in getting us there. But from that initial meeting where the board was reconstituted, she stood out as an outstanding leader, and the whole board listened to what she was saying. Always.
Look, I just want to say I was in the room with Governor Barber when he decided to appoint Dr. Anthony, and there had been a little bit of tumult at the board leading up to that, and Governor Barber wanted her involved because he thought she was honest, had good judgment, which I thought were 2 characteristics that I think anybody should aspire to. He was right.
Yes. Well said.
Thank you. Thank you.
All right. We'll continue to appreciate Elaine in the days forward. Continue to miss her. She would tell us to get on with the agenda, however. Okay?
Yeah, I do need to point out, we'll need someone else who will be willing to move to adjourn.
Okay.
That was her specific job.
We're not quite there yet, but I'll look your way at the right time. The first item on our agenda is the approval of the minutes from January 14th, 2025. Have y'all had a chance to review those minutes? There is a motion. Is there a second? All right. All in favor, say aye. Aye. Any opposed? All right. Dr. Edney, we're glad CDC You haven't gone to the CDC yet. All right. We hope you stay here with us a long time.
That is my game plan this
But
year.
the floor is yours for your.
Thank you. And I do want to emphasize the importance of National Public Health Week and thank all of you for your service to public health in Mississippi by serving on this board. And I want to thank all of our workforce throughout the State Department of Health statewide for everything everyone does and promoting and advancing the health, well-being, and safety of everyone in Mississippi. I'm grateful for everyone in the room and for all of our folks at all the county health departments and all of the environmental support areas and WIC and everything else that we do statewide. So public thank you to everyone working in public health. I want to have a couple of recognitions as we get started. Is Teresa Wyndham here? Okay, well, Teresa is online. I just found out yesterday that Teresa, who oversees our EMS Bureau and our Department of Acute Care Services, has done a phenomenal job helping us get our EMS work in top-notch fashion over these last 2 years. She's been appointed to the National EMS Advisory Council. So Dr. Carlton, that's a big deal. Is it not? And just, you know, a sign of recognition of the excellence that we have in many of our leaders. And is Vicki Todd here? Hey, Vicki. Vicki, I wanted to publicly thank you. Let the Board of Health know. Vicki came to us. She failed retirement the first time. So she was in state service a very long time and an HR expert. And I was so thankful that Chris was able to snag her into our work because we've had significant needs for developing our Office of Human Capital into a more robust and professional HR division. And Vicki has brought us a very long way. Unfortunately, but fortunately for her, the private sector is calling, and I'm a big believer in take care of your family. But I'm very grateful in what Vicki has done for us in a relatively short amount of time. I just want to publicly thank you, Vicki, for coming out of retirement to help us as you did. Thanks so much. The time since our last meeting in January, as you can imagine, has been busy as we're almost finished with our legislative session. The legislature has not had a final sine die yet. They have a joint resolution going till April the 15th if needed, but the bulk of the work has been done and most of our stuff has gotten through. We'll go over the legislative agenda and the impact of the session with you in detail in just a minute when Logan presents to us. And you can imagine that during the session that consumes the vast majority of my time. But thankfully, the work of the agency has been able to move forward accordingly. Let's see, if you go to the next slide, Austin, you know, my new phrase is we need to make public health boring again. You know, and when public health is above the fold, it's usually not good, but here it is good. I want to show you the Pontotoc progress. We're above the fold, and this what it's a, you know, Dr. Lampton, you know about community newspapers very well, but this is what I like to see when reopening of a county health department is a big deal for our county. So the Pontotoc County Health Department is the new unit is open. The old unit kind of fit the old mold of, you know, a building that was well past its prime from the 1950s. And Pontotoc County has built a beautiful brand new building that we all can be proud of. I was very happy to go participate in the opening of the new location. And it was extremely well attended. All the appropriate local and state leaders were present. We had city, county, and state representation there, and yeah, it's the main comment I had is when you see a community investing in their health department like this, you know it's a community that cares about the health of their people. And so what I would like to share with you is that, 4 years ago, we had county health departments that had snakes dropping in from the ceilings, and had one that had had armadillos in it, another one had raccoons in it, and it just was not an appropriate environment of care for folks. And we just set the policy that those who need to come to the county health department need an appropriate environment of care, just as we have when we all go for our health care. And we have come a very long way in those 4 years with counties really stepping up. Remember, these are county-owned buildings. They're not our buildings. So here's a great example where counties are upgrading, they're investing and renovating their facilities. We're helping them out every way that we can. But when we see new facilities come online like this, my comment was, this is now the new standard. And so as we think about county health departments, we don't need to think of the old timey buildings that we've had for so long. These are now the new facilities that I'm so proud to be conducting care in. And let's see, Dr. Dotson, how many? So we have one county that's getting close to being renovated. We're starting work on another. How many counties do we have undergoing renovations right now?
About 4.
About 4. So, that's in 4 years, that's at least 8 that I know of, maybe closer to 10 who've had substantial renovations and really modernizing how we provide core public health in our communities. Had a great meeting in Humphreys County earlier this week, and was so proud that the gift they gave me was a gallon jug of Hoover sauce from made in Louise. But we've been working with Humphreys County with their project of trying to get emergency services back in their county. They lost their hospital over a decade ago, and have just had a strong desire to upgrade their access to emergency care. And the congressional delegation has been working with them, and we've been working with them to try to help guide them through that. What I'm most proud of is they asked me to come down and do a community meeting with them, mainly about community public health and their county health department, and a great turnout. It was Logan, I want to say about 60 people showed up, and all the appropriate community leaders were there. So it's really encouraging when we have counties who really do care about their county health department and are willing to be engaged with that. So we'll continue working with Humphreys County. They were one of the counties that the legislature had granted a CON exemption that we'll talk about in just a bit. But overall, I think it has been a very successful 3 months. We still have a lot of challenges, but the opportunities are that where we're making strategic investments and really leaning in are paying off. I was a little frustrated because our 2025 health rankings came out the week after the January Board of Health meeting. And I want to go back and kind of rewind for you, where we were 4 years ago. If you remember, I showed you where our Commonwealth rankings were, and we were so far back in the pack that the only reason we were 50th is there just wasn't anybody else to make us 51st. But in 2023, we were closing the gap and had improved health metrics more than any other state had, and had at least caught up with the pack. And just like a marathon runner, we're just steadily doing the work with the goal in mind. And 2024 was the first year that we, in my lifetime, got off the bottom from 50th to 49th. And then January, the week after our Board of Health meeting, we got a ranking of 48th. And I told y'all before, I've never been so proud of being 49th in anything. And I'm sure mighty proud of being 48th, but we're 48th and rising. And so already got our eyes set on Alabama, who's 47th. I think that'll be pretty easy. But we are determined to advance and population health outcomes and raise our rankings there, not for the sake of having, better ranking numbers, but we know what that translates into, that the difference between being 48th in the country in public health metrics and being below 50th. I mean, that's where I pointed out to you, we're reducing our potential years of life lost before age 75 in a very impactful way. Those numbers continue to come down. That we've made progress in maternal death. Now we've got to make progress with maternal morbidity. And, and as we make progress with infant mortality, I mean, that just means more Mississippians are living longer, having healthier lives, and are able to contribute to the health of our community and economy in a robust fashion. And the message, we've done it in education, we can do it in health, is resonating. And now, we're proving that raising awareness and being strategic with our work is starting to pay early dividends, but very encouraging dividends. And certainly all my colleagues in Region 4 are paying attention to what we're doing. So things like the OB system of care, if you reflect on that outside the pandemic, that's probably is certainly one of the most impactful things the Board of Health has done, certainly in the last 20 years. I mean, going all the way back to institute the trauma system. So, as we institute innovative policies that are designed to accomplish a purpose to improve population health, then we will continue to see our rankings rise. So, with that, Mr. Chairman, I thought most of our time would be better spent looking at the legislative session, reviewing the appropriation numbers for our budget, unless y'all have any specific questions.
Are there any specific questions? Before Logan comes up, I do want to recognize Public Health Chairman Hop Ryan, who is a champion for public health.
Pop, it's over here.
It's been a difficult session, Senator Bryan, and you led with exceptional grace and patience and diligence for the right thing. So I did want to say thank you for everything you do for us. And I thank the board, on behalf of the board, we appreciate your great work for the state.
If you're going to say nice things about me, please direct them to Dr. Cheney. He's the only one of you who can vote for me.
Senator Bryan, before we get Logan forward, is there anything you'd like to say?
I come because y'all know more than I do.
Well, thank you for being here. All right, Logan, the floor is yours.
Hang on, look, and I apologize, Mr. Chairman. I want to make one other recognition. I want to ask Lauren Hegwood, who's our communications director, to come up. And I want to review with y'all very quickly our latest communications campaign, looking at the public health emergency for infant mortality and our Saving the Smallest campaign. And right now, let me have everyone in communications stand up, if you would. And Lauren, introduce everybody quickly.
This is some of the communications team. I'm incredibly proud of their dedication and the work that they do every day. This is Greg Flynn. He heads up our public relations and external affairs. Jared Couch, a lot of the campaigns you see, he's the one that heads those up. Cedric Washington, he is one of our graphic artists. Jim Newkirk, he takes care of the website for us. Andrea Dilworth, she also handles PR. We have Brandy Stewart Alford right here. She takes all of the photography and handles a lot of our projects as well. And we have Alston over here. And then down front, you have Miss Lynn, who answers the phones. And then you have Lauren Button and Martha Grace Gray out here today. But we have a great team and they're very dedicated. I'm very proud of each of them.
I am as well. Thank y'all so much.
Well, good morning. In August of 2025, MSDH declared an infant mortality crisis. In response to that crisis, our team, along with some of our partners, created the Saving the Smallest campaign. As you can see, the Saving the Smallest campaign is a public awareness campaign launched in response to the infant mortality crisis we face in Mississippi. Our focus is to promote and educate the public on MSDH initiatives surrounding all maternal and infant health. The goal is to connect families to trusted, accessible resources before, during, and after pregnancy. So why does this campaign matter? This campaign was created in response to the alarming data and real-time community feedback. As you can see, Mississippi has the highest preterm birth rate in the nation. Infant mortality rate is more than 3 times the national average, with over 5,000 born preterm annually in the state. We know the significant disparities exist, but most of them are preventable. This leads to our core message. Our goal is to make sure that families have the knowledge and resources they need to prevent infant deaths and give every baby a chance to see their first birthday. Many infant deaths are preventable. Healthy moms lead to healthy pregnancies, which then lead to healthier babies. And every baby deserves a chance to reach their first birthday. This leads to the creative strategy. As you'll notice, it's minimalist with emotional visuals. You'll see that we have familiar baby items without the most important part, the baby. It's designed to create a moment of pause and reflection and reinforce the emotional truth that every life matters and every baby deserves to thrive. As we were talking through our target audience, it's easy to say every Mississippian, and it's true, but we wanted to make sure that we reached the audience that would be impacted the most. This includes expecting and current parents, partners and spouses, grandparents and extended family, caregivers, and support systems. The campaign approach was simple. It was to meet our audience where they were. Obviously, that's social media is a huge part of it, but it's a multi-channel rollout. So we have video and digital in various sizes with various messages. We have rotating and static ads across all websites with retargeting ads as well as geo-targeting ads. We also have outdoor and billboard ads. We've learned over the years that our billboard ads can be quite successful with the right messaging. So with that, you'll see the stars. These are our highest impact counties. We wanted to make sure that we were in those counties and we were very visual, not just on digital and TV and radio, but also billboard. You'll also see newspaper ads. We were able to place half-page full-color ads in these publications. As you'll see, the newspaper ads have more copy, more information, because we have a captive audience and they had the time and the space to read more about it. You'll notice on the newspaper ad, we have a QR code. That QR code leads to everybabyfirst.com. This is a website specifically dedicated to this campaign. This campaign allows us to provide resources for parents and our target audience to get more information, to go somewhere quickly to know that they have support. Our key messaging, we wanted to be clear, consistent, and include attainable goals. This included early and consistent prenatal care. Very early on in the campaign, we realized through our analytics that a lot of our audience was clicking on prenatal care ads. So this allowed us to get with our field services team, our pharmacy team to push out messaging that we provide prenatal vitamins at every county health department, whether it's for a pregnant woman or someone who is wanting to become pregnant. We also have messaging with healthy nutrition and weight management, avoidance of nicotine and substance abuse with our Office of Tobacco team and our MSUD team. Our Safe Sleep team has incredible resources. We've been able to connect with them. We also have the importance of postnatal and infant checkups, and then of course our WIC team with breastfeeding and infant nutrition support. I encourage each of you to go to everybabyfirst.com. We have lots of resources for families. We're very proud of this campaign. Thank you, Dr. Edney and leadership for allowing us to dream up this campaign. And we truly hope that it makes a difference in our state.
Thank you, Lauren. And I want to point out, this is for sure our third major campaign. We had our syphilis and congenital syphilis mitigation campaign that was extremely effective and very much along these lines. And then our immunization campaign that had extremely good uptake. And I'm confident that this campaign will help get the message out on some of the simple things that can be done to prevent, especially those neonatal deaths, but all of our infant deaths. So thank y'all. Good job. Logan?
Good morning. Thank you, Mr. Chairman, Dr. Edney. Okay, first time to go over the board legislative items that we approved earlier, that y'all approved earlier on the last board meeting. Every year, we have the annual controlled substance law, and that bill has been signed and it's already, or it's effective July 1st, but those are the 4 different substances that were scheduled this year. The second item, every year we have a request for the the local government's rural water systems revolving loan fund. This year we asked for 8.3 million. That's a 5-to-1 match. So estimated we should have around $41,500,000 in loans available for that program.
Now, I would point out, the last 2 years, we've had more questions about the dollar figure, and what we present to the legislature is what's the maximum amount to get the maximum drawdown. The number's gotten large enough that it's been getting more attention, but Bill, I believe starting next year, that number should be coming down.
Yes, sir. And it has to do with the not ARPA, which some of you might be familiar with, but with the bill money, bipartisan infrastructure law. That is going to be sunsetting. The last portion of that money comes out this year. And so then the funding that would be coming, that we would be applying for at the state level, will be back to the standard allotments that are offered, anywhere from like $10 million all the way down to $5 million. So there's a range to it depending on congressionally directed spending. But that's why the number will drop when we see this next cycle.
So there's been more opportunity the last few years, and that opportunity is going away. So that number will be dropping.
We asked for an increase this year for fee increases for our food protection program and on-site wastewater. I don't have, it's 3 different fee increases between now and 2029. And Doc, I don't have it on here, but that should save about $3.5 million between the 2 programs total. With the increasing those fees and getting the programs back to sustainability.
I believe in the food protection area, this bill will close $1 million deficit gap that we've had. And then on the water side, that was going to be $2.5 million or so that we have gotten ahead of. So we were being hit $1 million a year on the food side, and we were looking at a potential $2.5 million a year on the water side without the wastewater side without these adjustments. So, this will be a $3.5 million to the good, really, in terms of protecting our state general funds. Mm-hmm. So from my vantage point, that's the same as a $3.5 million increase in our appropriation.
Okay. The next item, we asked for approval for a car tag to support the Public Health Trust, and that was granted to us. That's a mock-up of what the tag looked like, and we'll be working on that over the next year to get the commitments, I believe, that you need, the threshold number for that car tag. But we're approved and we're good to go on that. So,
The board's gonna wanna know about that so we can get some of those.
Yeah, no pressure, Mr. Chairman.
No pressure. We should be the first 11.
The next item is, we asked for some, since back on the trust, that was established obviously last year, and it wasn't funded initially. If you remember, in our last board meeting, we had asked for, we were gonna use cannabis money, originally. If a percentage of that, what wound up happening is we got a direct $1 million appropriation to the trust. And that is in our appropriation bills. That would be seed money to, that'd be the first money into the trust, actually.
So there was universal support and financially supporting the trust. It was, our language was supported all the way through until Senate appropriations. And there's just a policy issue on the Senate side, not to support diversions, which I respect and understand, but there was support in just funding, helping us fund the trust. And as we said, none of the private foundations want to be the first dollar in. So the state of Mississippi will be first dollar in, and that will open the door to help us solicit funding outside of the state funding.
The next item, this is the cleanup language from last year. In the last session, there was some language in a bill that stripped, that prevented our dental hygienists at the Department of Health from doing some of their work. And this just cleans that up and puts the language back in it that was removed prior to this last year. And Doc, the next one, this is the infant mortality review panel creation, House Bill 1637. Doc, I'll let you take the lead on that.
Yeah, this is actually extremely impactful legislation for us for many reasons. It does, it pulls infant mortality review out of child death review, which was very necessary. We had done that administratively just to put particular attention on the specific deaths of babies in the state, where we're just like maternal mortality. We're actually studying the cases of the women who die related to pregnancy. We needed to be doing the same thing with the babies, and not just looking at a global picture, but looking at specific cases as well. And we had authority to do most of what we needed, but when we're looking at neonatal deaths, those are all virtually all tied to the health of the pregnancy. So looking at the mother's records in a confidential manner is really important to see how maternal morbidity was associated with the infant's death. And we now have that specific authority that we did not have before. And we now have specific authority to study fetal death, which we did not have before in the same manner as we do all of our death review. So it was going to help our death review panel in the fetal infant space be able to do their job much better and give us much better information to help develop policy. And then it also very specifically got privacy exemption related to radiation health. So hospitals, other healthcare institutions who had sources of radiation for therapeutic reasons, such as cesium, cobalt, whatnot, that we no longer have to publicly disclose where those sources are, because those sources can be used for other purposes. So now that's just exempt from public records request. And then extremely importantly, our morbidity and mortality work related to our systems of care, and that includes trauma, but now also include the OB system of care. It allows that performance improvement work, which is really sensitive information, where you're studying where things did not go well. That we all in healthcare know, morbidity, mortality review work has to be done in private, not in secret, but in private, and just makes it non-discoverable, so that those committees can do their work and identify where we can do things better. So now we have that same type of privacy coverage, and we don't have it for all of our work, but we have it for, according to the statutory language, any any of our review work that's required by statute, which would be things like maternal mortality and now infant mortality. But also if it's required by regulation of the Board of Health. So that, that keeps it at a high level, important morbidity mortality review, but it allows us to do that review that most of the times in state law that we have to do. So an extremely impactful piece of legislation that helps us in many respects.
But it's accurate that this structure of this is substantively the same as what you've been doing for child death reviews since 2006.
Correct.
So we're not creating some sort of, the state's not creating some sort of secret police.
Exactly.
Going to go out and
We specifically lifted the privacy language from child death review from 2006 and maternal mortality from 2017, which was reaffirmed by the legislature, and use that exact same language in statute to cover all the morbidity mortality work that we do at the state level.
so it's not a new concept. You're just making it specific to
Exactly. And also it's paired with other states, the way other states do it.
Thanks for clarifying.
Yes, sir.
Have there been any challenges, legal challenges historically to the child death work that we've done? And do you anticipate legal challenges to the privacy associated with this new rollout?
I don't know of anything within the state. We could look at if there have been challenges in other states, but Dr. Davis, the hospitals you operate in have M&M committees, and all of that work is protected. That's all done. It's the same as being in executive session, and so it just extends that, that non-discoverability to a hospital's work as they look to make things better. And performance improvement really is one of the most powerful arguments for systems of care, is you're able to study, at a state level, the outcomes and look at where pain points are and where failure points are, and then look at how to fix those. And it's still it does not exempt any of these cases from normal discoverability. It just can't happen through us. So a trial attorney cannot, subpoena records from us related to specific cases. They can still do it externally, but not through us.
Very important.
It allows an honest discussion instead of a defensive discussion. And what we really seek in this is trying to improve care.
Right. And that bill is at the governor's office now. Conversations I've had, I don't foresee any problems. Chairman Bryan was exceedingly helpful in us getting this done. So I want to thank you.
I was just going to reiterate something you said a moment ago. All of this information is discoverable. We just have to go back to the original source. So if you have a medical malpractice case or anything, all of these records are available. If you've got a client, you can go get these records from the source. All it does is, in a practical matter, prevent someone from going and getting this information from the panel and then searching through it, hoping to find potential plaintiffs. I mean, frankly, that's what the practical effect of that is. And I think that's the correct answer and the meaningful answer to the concerns about privacy.
Yes, sir. And then I like to remind people, these are legislatively mandated panels. So these aren't MSDH panels. We're assigned administration of the panels, by the legislature, and we provide the epidemiologic statistical work that the panels need. And then we assist them in constructing the reports, which we always, every year, issue reports related to our mortality review work that go to the legislature and are externally facing on our website. So every year, we have infant mortality review report. we have the child death review report, and we have the maternal mortality review report. I keep all three of those reports on my desk because they're, to sit there to remind me, keep our eye on the ball. So, this is it. But I will tell you, in my almost 4 years serving in this role, most of our actionable information comes out of those studies. That's where we see where a lot of the problems are, is through the death review. And now as we're able to extend that into morbidity review, we'll get even more information. Because right now we're only studying the worst cases. As we extend that, as I like to point out, there are a lot of women who aren't dying today that 10 years ago would die related to the pregnancy, but they still have end-stage renal disease. So that they're on dialysis, or they have heart failure, or they had a stroke that just didn't kill them, but they're never the same related to complications of pregnancy. So that's where our morbidity work will extend to, is studying those cases.
Okay, I'm gonna skip the 3 CON bills and we'll come back and do this as a group.
Sure.
Okay, the next item is the Ibogaine drug development clinical trial.
These are the bills that were directed at us, not our bills, but
Was there a slide right before?
I was.
Oh, that's the, okay, sorry.
So what this bill does is establishes the Ibogaine drug development clinical trial. And our role in this is we may select a consortium to conduct the clinical trials. And that will include a drug developer, institution of higher learning, and hospital. And then MSDH will enter an interagency contract with the consortium's lead institution using legislative appropriated funds. So that's the main overview. Doc, do you want to?
it's a significant assignment for us, but it's mainly administration and the funding is there, so it won't be a financial burden to us.
But who does it?
We shall see. It has to be a research hospital, which has to be
Like, in terms of the staff at the Department of Health that has nothing else to do. Who's that? What group is actually going to take this on?
that I've not decided that yet. I need to see what resources we have. And I'm looking over here at Tanya Regilio and the health services area that, that may well be where it goes, but I could be talked out of that.
Matt, it's the only reason I bring it up, and Senator Brown and I having this conversation as a part of my intensive confirmation hearing. It's great that we get the money, but but it seems like health and DFA consistently get a lot of assignments with time sensitive thing, but that means that there's a certain number of hours in the day with a certain number of state employees that it's either going to end up getting contracted out, which is not always the best solution, or if we're going to start doing these things more and more, there needs to be capacity established within
We'll have to.
these, whether it's policy and planning or whatever it might be, to be able to actually monitor these things so that we don't end up, effectively becoming a private equity investor in some sort of, drug development company.
Mr. Perry, another area likely where it will go would be our new Center for Injury Prevention, which is where our opioid litigation work is and our behavioral health work is. But I don't have, currently today, I don't have the capacity to add something like this and just drop it on a team. We'll have to build it out.
So this, going back, this is back to, there's 3 CON bills here. This was passed back in February. It's law now. Just a brief overview, it targeted CON relief for select facilities, partial deregulation via increased thresholds, restructured UMC CON exemption, expanded Medicaid participation flexibility, and directed for future CON reform analysis.
This is the bill that was passed last year that was vetoed, and the legislature very quickly adjusted the language related to the veto message and moved this bill through it early in the session. So and the study component at bullet 5 is the study that we completed recently. And that the new pilot project, I think is going to give us more information that we'll need to continue to study. So I think you're all familiar with that bill.
The next bill is House Bill 1622. This is the small community pilot program. Defines small community hospitals, provides 1 to 2 CON exemptions for qualifying hospitals, limits exemptions to main campus, plus 5-mile radius, and specifically excludes off-campus facilities from exemption. Maintains CON moratorium and 35-mile proximity protections. It allows geriatric psychiatric units at qualifying hospitals without CON. Authorizes limited ESRD and dialysis facility licenses for qualifying hospitals. State health officer decisions issued regarding exemption applications are final without judicial review. Creates CON exemptions for facilities in Issaquah and Humphreys counties with specific limited exemptions. Requires unsuccessful party, any unsuccessful party who appeals a final order approving a CON application issued by the department to Chancery Court or the Mississippi Supreme Court to reimburse the applicant reasonable attorney consultant and other fees related to the appeal. And Doc, if you want to add anything to that.
When we had the expert
I do.
in the room, and Mr. Chairman, as I remember, y'all consolidated several legislative items into this bill, but it does take the concept that the board had advanced in terms of rural healthcare exemptions and constructed the pilot project. And, you know, the definition for small community hospitals is it's not based on the county, but based on the community. And a community of 15,000 or less would qualify, and then there's special exemptions in the Delta. Mr. Chairman, the core Delta counties as defined also, they were the ones that got to get 2 exemptions. Yes, sir. So everybody gets 1 unless you're in those specific counties, and you get 2. So, and we, you know, and it's an exemption from any of the CON, required services that's in statute. They can pick 1. The only thing we're involved with is making sure they qualify for the exemption. And then we'll take the project they're doing and, involve that in the state health plan.
The need to evaluate the impact, capacity, access, and system efficiency for the various moratorium, whether it's nursing homes, home health, et cetera. Don't we have to deliver something by December 1st?
Mr. Chairman, I thought we had 2 years to do it.
We do.
But 2 years, okay.
And I took the assignment, Mr. Perry, is that we had a legislative directive to study the 3 moratorium areas and to generate a report before the legislature has to act again, which is 2 years. And that would, that, in our opinion, addressed Judge Reeves' concerns in terms of not the moratorium that in place now that he struck down with home health, but that'll be determined in court, I'm sure.
Yes.
Could every qualifying hospital or area pick the same qualifying waiver, or whatever we're calling it? Or I mean, could you have every one of them picking the same thing, or is there a limit on that? Okay.
Yes, that we don't have any influence on what service they choose. We just determine whether they qualify for the exemption.
The final version of the academic exemption to CON laws for UMMC, does it require that, or does it allow for bypass of the CON process if it's on the main campus or immediately adjacent to the adjacent to the main campus, or does it, yeah, I saw the wording on your slide said the Jackson area. I think the bill originally required that any additions be on the main campus.
And there was a footprint, Chairman Bryan, as I remember, the footprint went from the main campus all the way down to Medical Mall.
For all practical purposes,
Yeah.
it's the main campus.
Okay, all right.
I mean, I think it includes the middle.
Yes.
But it's all in Hines County, for instance.
It's all in a rectangle around where UMMC is.
So there won't be an issue with the new cancer center.
Sure.
That's within their exemption.
Okay, sure, I got that. For instance, the current UMMC facility in Madison County, is that within that triangle,
No,
that
it's a-
rectangle?
It's a rectangle in North Jackson.
All in Hines County then? Okay.
Now,
It's
So, Chairman-
it's a rather small rectangle.
Sure.
Dr. Davis, they still would qualify for their rural hospitals to apply for a rural exemption.
Sure.
And those rural, if they're in the right counties, in the communities.
Chairman Bryan, I think y'all handled this very delicately and very efficiently, and it's going to be a lifeline for a lot of community hospitals. But I think it's done in a very limited fashion as the pilot, and the utilization of the exemptions was an exceptional idea. So I want to praise y'all for this. I think it's going to really be a boon for small rural hospitals that are struggling.
Dr. Eddie, maybe you could, just, since we'd had the conversation before, what y'all did on, dialysis at home to clarify.
Yes, sir. Remember the conversation related to confusing language, and it turned out to be in the state health plan related to the training centers for in-home dialysis requiring CON, which made no policy sense. And as we were reviewing that, it was a memo in the state health plan that was ill-defined that we were able to clarify. And so it was not in statute, it was not in regs. So we did a clarifying memo in the state health plan that corrected that.
So the practical impact is that you don't need a CON to provide dialysis services in somebody's home.
That's correct.
Weren't there two other slides about CON? Should we look at them before?
Last slide was, this bill is still due from the government. This is Senate Bill 2474, and it establishes the Rare Disease Task Force and then amends House Bill 1622, replacing the term license with exemption for the pilot program. And that's the extent of what 2474 did. It was the last bill. Of course, we're still waiting on that. As far as our impact is, it makes that change to the pilot program and then defines or references the definition of the public health regions.
Can I ask a question about a different bill that's not I do not claim to be completely knowledgeable in this, but my understanding is that the ARPA money that we were using for rural water systems that we've talked about a lot in these meetings, that the law was changed, that it now needs to be spent by sometime in the fall, maybe it's October 1 or September or something like that.
That's right.
And then if it doesn't, then it reverts to something. Where are we on the rural water money? And is that accurate? Did I just describe that accurately? And what's the impact of whether it's rural water or something else in terms of the programs that we're administering?
Yes, sir. And that's all the ARPA money statewide, all agencies. And I get a weekly report on the ARPA spend. Bill, what are we at? We're at not quite 300 million of the,
I believe that's an accurate.
we're approaching 300 million, but there's going to be about probably 100 million that's not going to be spent in time. And I believe it gets diverted to MDOT.
And I assume that we're in fairly constant conversation with the various rural water entities
Yeah.
to see if there's anything that, I mean, I know this has been going on for a couple of years, but
Yeah, they,
anything else that we need to be doing?
there's nothing else that we can be doing other than staying in communication. I mean, that there's no issues in terms of processing the funds. It's just getting the work done. And it's the same challenges, you know, the supply chain issues. I know a lot of associations pivoted away from new water sources because they just couldn't get the wells
Correct.
drilled. And so we facilitated a lot of pivoting into projects that they could spend. And we'll continue to do that for the short period we have. But I expect it'll probably be about 100 million.
It's just that it's a little frustrating. I know it's not the health department, it's just a little frustrating that there's such demonstrated water infrastructure needs. And the legislature made a substantial sum of money available. And I think it's great that we're gonna spend it on roads and have the money not go to waste, but it's a shame that there'll be $100 million of money that could go to rural water that will, you know, not happen.
Right.
And it would be, I think it'd be useful, even if there's just a little after action report of if there's lessons that were learned throughout this process that can be memorialized while the memories are fresh, so that if another initiative is rolled out, we don't make the same mistakes twice. When I say we, I mean the royal we as a state.
Sure. Because it lessons that need to be applied to rural health transformation. Right.
Yeah, I mean, it's a great point that it can apply to other, you know, substitute some of the work for water, but for other sectors, but also specifically as it relates to water. I don't think the need is going to go away. The dollar amounts needed are just going to grow. So some point in the future, somebody else is going to say, we need to do something to help rural water systems, and it would be a real shame if they make the exact same mistakes that were made with this. Not to say it was all a mistake, a lot of good things were done, but it's just unfortunate that $100 million will not be used for this. I mean, Senator Ryan, if you think that's type of information is helpful as y'all think about this in the future, if it's not, then we won't spend the time doing it. I mean, do you think is that useful or not? Or were you too busy sneezing to hear what I'm saying?
I'm having trouble hearing. Can you say that
I
again?
mean, the idea of doing an after action report of why is there gonna be $100 million left on rural water?
Well, yeah, but e pluribus unum, you know, we went from Hiroshima to, from Pearl Harbor to Hiroshima in about 4 or 5 years. We don't seem to be able to get anything done in 4 or 5 years. I don't understand any of it.
I take that as a yes.
Yes.
I'm apoplectic about it, but I'm apoplectic about many things. I don't understand it all. I don't know. Yeah, but you're right. We need to look at it.
There were a lot of lessons learned just from our work, just in our little universe through the ARPA days, that we don't need to make the same mistakes twice. Okay.
I'm gonna have one more item. That Senate, Resolution 71, paying tribute to Dr.
We were so proud, Dr. Anthony, to see the legislature officially recognize her. Just shows how beloved she was in so many ways.
Mr. Chairman, that concludes my report. If there's anything else.
Mr. Perry survived his confirmation process.
He did.
Yeah. Hob did everything possible, Senator Brown did everything possible to make it not happen. You know. It was actually I thought it was a really good, in all seriousness, I'm teasing, of course, by Senator Brown, but I thought it was a good conversation made me think about lessons learned over the last 6 or 7 years. He did blame me for the pandemic, but
I think we do too. It was your fault, wasn't it? Mr. Dillon, what about appropriations?
We're gonna do that next, Mr. Chairman, with
Okay.
Mr. Bean, but y'all, Logan, let's see, Logan, this was your 7th session. You came on in 2020,
Yes, sir.
so, and you and I have had four together.
Sir.
And I just want to just say to the Board of Health how important this young man is to accomplishing our legislative agenda. He's probably one of the few under the roof at the Capitol that doesn't make everybody mad, and has, he has done such a good job of, being a good servant leader down there and being helpful and, staying in our lane, and is a trusted, voice when there are questions, about our legislation. So I just want to publicly thank Logan. I want to point out, this is a second year in a row, he helped us go at 1,000 down there. So we accomplished all pieces of our legislative agenda, once again, and a lot of that is through Logan's hard work. Thank you, buddy.
You call him a young man, but he's not as young as he used to be.
You have to be a first-time father. So I want to make sure you and everybody's up to date with your DPT vaccines, okay? That new baby.
We'll start seeing more gray hair.
Thank you, Logan. Thank you. All right, Mr. Review. Lucretia.
Good morning.
Morning.
As Dr. Edney mentioned, we're gonna go over our appropriation. Our House bill is 1908 is sent to the governor. It has not been signed yet, but it is there for him. I want to go over briefly our ask for 27 and what is currently in our appropriation bill. As this slide, y'all are familiar with this slide, identifying the our buckets. And as you can see, for our request for 27, the core agency core operation public health, we are looking at right around 27 million. I directly named agency programs, we are at 33 million. And those appropriated for other purposes at 27, and the trauma care system is holding steady at 13 million. Just a brief overview as far as our funding. As you're all aware, we as an agency receive general fund, healthcare expendable funds, tobacco control funds, and for this time, we also requested a reappropriation of capital expense funds for those funds remaining that we had left over from the Jackson Water litigation. So those would carry forward to 27 for us to use as well. And there is one other item that was added in our bill, and that was some opioid settlement funds, which will be going towards our IMSUDS program, and that was 4.5 million. Here you can see a comparison just looking at from FY26 to what we asked for FY27. And again, it's still in that same format for the various buckets, our operations, our name programs, other purposes, and for trauma care. And we are right in line. Our general funds received in comparison to the previous year, I want to say it's a slight increase of 600,000, but we are pretty much in level funding. Again, with our healthcare expendable funds and our tobacco funds, all held steady with level funding. Are there any direct concerns or direct questions regarding any of our funding for 27?
Just want to remind y'all, the first two buckets are what we run the agency and administer all our public health programs through. The third bar graph are our pass-throughs, and that drop, it was really, Lucretia, it was level funding, but Lucretia's cleaned up some things that should have been over in second bucket, which shows one reason why that bar graph is higher. The dollars are fairly even, but just making it read more true. And then the trauma fund is that fourth bucket, and that's it's been really important to shine the light on that. You remember the catastrophic event for our budget was when the trauma fund was moved into our appropriation, the 2016 or 17 session, and they backed those funds out of our appropriation for operations. So I keep that separate so they see this is the trauma fund. This is not the agency. The trauma fund is mostly a pass through. And we advocate for the trauma fund, and the trauma fund does need more support, but that is not, core agency operations. Those first two bar grants are really our funding. The big benefit is, Lupita said, 4.5 million of opioid settlement money that will go into direct patient care with MSDH program that provides free access to care and medications for opioid use disorder statewide through the county health departments. That's going to help us expand that work and augment our staffing, expand our medication options, and it's really, going to supplement that program a great deal.
Is the trauma appropriation a fixed amount, or is this in addition to what we get from the car tags?
It is, there's the car tag revenue, and then the fees that are added on to like motorcycle helmets and ATV sales, and there's a whole laundry list. And I remind our appropriators that those fees haven't been adjusted in quite a while. And those fees don't come to the agency, it goes to the trauma fund. But we've got the fees that go to the trauma fund, and then this is state appropriation from the general fund.
Okay.
They increased the appropriation year before last, I believe, from to where it is, but it's been level the last 2 years.
And I'd also like to point out that our medical cannabis funding is also remains up with the 7.5.
Yeah, we have adequate funding for the cannabis program. There's been no need to, ask for an increase there. But I would point out to y'all, the reason we've not needed to ask for a lot more money has been focusing on the fees that had fallen too far behind. And the program areas that should be fee-based that were running in the red, getting those back, just to even has, over the last 4 years, over the last 4 sessions, has accounted for about an $8 million swing with our general funds. So there's no need to ask for more. We're just freeing those dollars up in a more responsible way. I just don't think that we need to be using state taxpayer money to regulate, for-profit entities. That the fees should take care of that. So we're in much better shape. I'm hoping that we're mostly caught up. I don't know the many big fees that we'll need to adjust next year, but then trying to help our appropriators understand the statutory fees need to be adjusted about every 3 years, not every 10 years or 12 years. And then they can be smaller increases that still, keep our budget where it needs to be.
And lastly, as usual, I'd like to give an update on our campus improvements. You all have been coming on campus all last year. You saw the construction being done on the ARPA pharmacy warehouse, which is directly behind this building. It has been completed. The building is now under our possession. The next couple of big projects that will be forthcoming. As you all were aware of, the improvements needed in the Underwood building is broken into 2 phases. Phase 1B will be getting started soon. We're working with BLB, Bureau of Buildings, on that as well. The ARPA medical countermeasure warehouse in Pearl is also expected to be completed in June of this year. And lastly, I have on there the general R&R. We have entered into a project to have a mechanical assessment of our HVAC systems. As y'all are aware, the aging of the facilities that we have on campus, we just want to make sure that we have the heating and cooling that's needed for the buildings, and also it will help us in preparing to engage in some preventive maintenance. So instead of waiting to get things done, we can have a good plan in place to keep everything working smoothly. Are there any questions in regards to any of the upcoming capital projects?
Dr. Anthony, should there be a time the board see some of these?
Sure. The new building in the back, we call it the box, because that's what it is. It's a nice box. Right now we're going through a space utilization study. These projects predated me coming on, and we have to get the pharmacy out of its current location. We just have to. But we're looking at what may be some better options, because we are starving for office space on the campus. So we want to make sure the pharmacy operations are well secured in a good, safe location. And yet we still free up square footage, because we have too many programs that are in private space, around the Metro Jackson area, that we want to try to consolidate on campus into state buildings as much as we can and stop paying those leases. So we're doing this space utilization, but we will be happy if y'all would like in July to set up an official tour, if you would like to.
Would there be interest in that? So
I
maybe
always want to see a box.
we'll go see the box. It should
See the box.
I don't know if, I do have a question that's other than this, but
Okay.
I don't want to interrupt.
No, I will say, we have too much deferred maintenance in this building, and also the public health lab. And Lucreta has a good game plan. We're doing a comprehensive building evaluation to see what our needs are, so we can work with DFA to have projects lined up. We're worried about our elevators. That's going to be a big ticket item. The HVAC is not going to last much longer, but we have a game plan to be better stewards and do proper ongoing maintenance of our facilities.
I don't know, it's just, do you have more on? I think this would go to you. I was looking at the appendix in the board package for the contracts. And there's one that just doesn't seem right, and maybe they're just misreading it, but it's 640,000 to BDO Government Services Warren. And it says it's for janitorial services.
What page is that, Jim?
It's in the contracts and sub grants in the appendix. I don't know how to find it.
54.
54, bottom. So, I mean, what is that? 640,000 for an accounting firm for janitorial services.
Actually, our early intervention technical assistance.
Okay,
It's a typo on the document.
so what are we doing? So, first of all, glad to know that they're not doing janitorial services.
Correct.
Second, what are they doing for their early intervention?
So you'll remember back when we had the early intervention task force, there were a number of recommendations that they made to improve the program. We also had a corrective action plan with OSEP, and so they are helping us redesign those systems, helping us meet the corrective actions that we need to do, and also doing an assessment of our IT infrastructure related to that program.
Is that an ongoing thing, or has that work been done?
That work is ongoing right now. And so what they will produce at the end of that are recommendations going forward, and then we'll be responsible for that implementation.
Thanks. And the second one is the $1 million on GME for South Central on the next page. Why is it just to that one medical center? This is just my lack of understanding of the program.
Yeah, there were 3 commitments made when Office of Mississippi Physician Workforce, and Dr. Calderon's with us today, our new director. The commitments were made when it was at UMC under Dr. Mitchell, and as it transferred to us, the funding was there. We just were the ones that had to make the disbursements. And those were invoice reimbursement models. So they had done the work that was eligible, then we paid the invoices. Thanks. And it was South Central and Laurel, Greenville with family medicine program at Delta Regional, and then at East Mississippi, the in Meridian to help with their OB fellowship program. Okay.
And I'll just add that funding is very critical for new programs starting because it is a time when there's a lot of expenditure, but you haven't got any sort of funding coming in from CMS or other sources to support the GME.
I was just curious why it was just that one.
I think they were the last one to get paid, if I remember right. And that was
These
for,
are internal medicine or family practice residency programs that are being, a program that's being established at South Central
yes, that was internal medicine.
Internal Medicine.
And now they're looking at building a family medicine program there as well. Then the program in Meridian was family medicine OB.
And are both of those operational now? Are they accepting applicants now or have they matched residents?
South Central and Dr. Colorado, what you shared, they had a good match, I believe.
Yeah, they did great. So South Central just matched their second class, so they've got their some upper levels now that'll be progressing next year. EC HealthNet has had a fellow in their program. They're recruiting more right now. And the Delta program was more for expansion of a new clinic for them. So it wasn't relegated to a new program. It was expanding space there.
How many residents per year in Laurel?
So they're approved for 10, and I believe they've kind of shifted some numbers around. I think they had 7 in their batch this year, but their full contingency would be 30 in a couple of years.
Gotcha.
Like so far, Dr. Carlin, as I understand, all of our new programs are doing well.
Man, 10 a year, that's a
Yep.
sizable program. I don't know what UMC's internal medicine.
Over
Match.
20, yeah.
Yeah, so that's.
And the data is
impressive.
The data from Dr. Calderon's office is pretty impressive that for the students who go to medical school in Mississippi and then do the residency in Mississippi, you said 79% practice in Mississippi.
Yeah, it's about 70%. It's higher than national average.
So a good return on that investment.
All right, any other questions for Dr. Edney? And so we'll plan maybe a tour of the box in July. Thank you, Ms. Tribune. Dr. Edney, anything else?
No, sir. Thank you very much.
Excellent. Our regulatory action agenda is very easy today. We've got a consent agenda, but we only have one item. But it's a reappointment to the Professional Art Therapy Council of Susan Anand from Madison County. Is there a motion to approve item 1 on the consent agenda? Is there a second? All right, all in favor, say aye. Any opposed? All right. Before we go to committee reports, when I made the motion about approval of the minutes, I may have said only January 14th, 2025, but there were 2 other board meetings. Forgive my obsessive compulsiveness, being sure we've approved all of them. But by acclamation, has everybody approved that those be included on that original?
The intent of my motion.
Yes, very good. All right. So just be sure in the minutes that we've approved.
Yeah.
The chairman, I do want to point out, as we were going through our fee schedule adjustment, and on the wastewater side, we had the support of Wastewater Advisory Council. They did bring to our attention needed regulatory change that they're asking for that we'll be working on to have ready for y'all in July. I just want to make sure the Advisory Council knew we were working on it.
All right, very good. We'll be working on it. Why don't we do committee reports? And we do have an item under new business, and we will have an executive session. Committee reports. Mr. Hubbard, anything from the legislative committee? All right, Mr. Perry, anything from the audit or the cannabis committees?
We need to schedule an audit committee. I worry about we might need to talk about membership, because I think that with Dr. Anthony and Bobby, I'm not sure.
You and I'll look at that.
Yeah.
Okay, we'll be sure it's fleshed out on the
And nothing on cannabis.
all right, nothing from CON other than what's been discussed. Dr. Cheney, what about maternal health? Anything? from
The
you?
only thing would be, and Logan discussed the
And Dr. Edney discussed the fetal and infant mortality review panel, and that's very important. On the OB system of care, the advisory committee is under the direction of Dr. Rachel Morris, and it has been formed, and they'll have their first meeting May the 12th, and then the PI committee will be formed after that. And on the OB system of care, the CDC locate the levels of care assessment tool. It's my understanding it's been voluntary in the past, and with the OB system of care will be mandatory. So that will start those. And Dr. Randy Henderson is overseeing our neonatal levels of care work. So right now we're on target to begin working with the hospitals by August with both maternal and neonatal levels.
So, yeah, that's all. All right. Very good. The other committee, Dr. Hayes Anthony was the long-term chair of the nominations committee. In her place, I'm going to name Beth Edmiston as the new chair of the nominations committee. And Beth and I have discussed having a nominations committee meet before July to come up with the slate for this board to vote on. And that will be the first item of business at the July meeting, is approving that slate. The other members of the nominations committee are Mr. Hubbard, Mr. Perry, and Dr. Griffin, and that will probably be a Zoom meeting before July. And probably would only need to be one meeting, but we'll see how it goes. With that, that's all the committee reports. New business, public assistance, state and local disaster assistance agreement. Dr. Edney, can you speak to this briefly? The agency needs the board's permission to serve as an applicant agent to work with MEMA and FEMA.
Yes, so this is a routine matter that just has to be enacted by the Board of Health for us to do this work with MEMA and FEMA.
All right. Are there any questions for Dr. Edney? If not, is there a motion to approve public assistant?
So,
That's all right. The motion, is there a second? Second. Any discussion? All in favor, say aye. Any opposed? All right. Old business. I do not have any items under old business. Does anybody have any old business they'd like to discuss? We had talked about doing some strategic planning at a different time than January. Dr. Edney will be looking at that. We'll probably talk more about that in July. And I would anticipate if we want to do it at a time other than January, probably October would be the time to do it. So the meeting in October, we may be discussing that as some strategic planning for this board, our annual strategic planning. All right. Any other comments or questions by board members? If not, there is a need for an executive session based on litigation matter that we need to discuss. So I need a motion to go into closed session to discuss executive session, but it's a litigation matter, so it's a program and personnel. So there's a motion. All right. So we are now in closed session. If everyone but the legal folks, personnel matters, and no action was taken in executive session. Our next meeting will be July 8th, 2026, and the October meeting will be October 14th, 2026. Everyone, if you'd like, you can go upstairs when we get done of the board. There is a little food there. Is there a motion to adjourn? All right, the deed is done. I'll have a good day.
Thank you.